Well, good morning, everyone, and Happy New Year. Welcome to our first SEOW general meeting of the new year. I'm Tiasha Fernando Backrack, one of the co-chairs of the SEOW. If you're a new face, so excited to have you joining us today. And if you're a returning face, we also love to see you here as well. I hope you've been enjoying the snowy weather wherever you are and staying safe and warm. So we have a really great presentation lined up for you today, and it's all about linking data and creating partnerships. And we're really excited to dive in. But prior to that, we just have a few pieces to get through. So please continue introducing yourself in the chat with your name, your agency and organization, and your position. And as always, general housekeeping, please keep yourself muted unless you're wanting to talk to the entire group, just so we can minimize some of that background noise. And as always, we'll also be recording this meeting and making that recording available to you on our website. So if you have any questions or concerns about that, please reach out to Junior Wadanasari, who is our SEOW coordinator. And with that, we're actually going to introduce Junior a little bit more to you all. Junior, do you want to come off mute and tell us a little bit more about how you're involved with SEOW?
Yeah, of course. Thanks, Tiasha, for introducing me. So my name is Junior. I am the new SEOW coordinator. I am also a graduate student at CU Anschutz. I'm a first-year student in the Masters of Science program in epidemiology. Just started this past fall. And as an SEOW coordinator, I do multiple things to kind of help out with the co-chairs and the steering committee, kind of just managing all the tasks that need to be done. I help manage the listserv, kind of help disseminate any publications, any newsletters that kind of come through our way. I also manage the website and kind of coordinate some of the meetings as well. If you guys have any questions or concerns about the SEOW, feel free to reach out to me as well.
Awesome. And then Junior, do you want to share a little bit about our structure for the meeting links that are going to be changing?
Yeah, thanks for the reminder. So kind of going forward, so typically in the past with every single SEOW meeting, we would be sending out one link for registration each time. But going forward for the rest of the year, I believe there are 5 meetings that are left, not counting this one. We're just going to be using one registration link. So when the link gets sent out through like an email reminder, when you sign up, they'll just have the dates for the rest of the year, and you can kind of keep referring back to that link. Of course, it'll be sent out periodically throughout the year, so you guys don't lose it through emails and stuff like that. But it just makes it easier to kind of just share one link and kind of keep that going. We'll kind of send out a calendar invite for the rest of the series as well, so it would stick into everyone's calendars as like a little notification that that the SEOW meetings are coming up. And then we'll be updating the website a little bit more frequently. And we'll kind of post that link as well in each reminder. It'll kind of give the details for specific, meetings that come up throughout the year and other events as well.
Awesome. Thanks, Junior. All right, so we are going to split into some breakout rooms now. We're only going to have about 10 minutes in these groups, but kind of chat about the following things, share your name, organization, and position, and what you're looking forward to accomplishing in your professional life this year. If you're looking to build your professional network, potentially if you're on the job hunt, this is a great opportunity to connect with some folks. And then also, we'd love for you to talk about what data sources you guys are currently engaging with and utilizing in your work.
Oh, maybe I should leave this meeting.
You guys could please mute yourself if you're hopping on the meeting. That'd be great. Thank you. And also sharing what experience you have with any linked data. All right, so you guys should get split into your breakout rooms in a second. Great. All right, Junior, Peter, you guys are seeing my screen, correct? Yeah, okay, awesome. I see some thumbs. Great. All right, well, welcome back, everybody. I hope your breakout groups were as lively and as lovely as mine. And we are going to roll into our main presentation today. So we have Courtney Everson and Alicia Clemens here from the Colorado Evaluation Action Lab to present today. I'm really excited for you guys to hear from these ladies. They have really interesting work to share with you all. So I will stop sharing my screen and turn it over to them now. Perfect, and I can see your screen, Courtney. Oh, though you might be muted.
Yes, I am. Thank you very much. Thank you for verifying you can see the screen. Let us know if you have any problems with the visuals at any time. Thank you for that introduction, and really thank you for the invitation to discuss opportunities to further promote cross-system health solutions through LINC data. We're excited to kind of elevate some of the work that we've been working on at the lab through several partnerships, including many in this group, and then talk about what this looks like for translating it into the work that you do, the data sources you have access to, and the goals that you are driving towards. Many of you might be familiar with the Colorado Lab, but for those of you who are not, just quickly, the Colorado Evaluation Action Lab is a social and health policy lab that supports all three branches of government in generating and using data to inform policy development and practice. And so this is really where we have an opportunity to move data into action, and that's something we hope to inspire at the end of today's presentation. So let me go ahead and move us into that goal for today. You know, when we think about what is our goal, we're really hoping to articulate what we call a model process for generating actionable data to address a variety of substance use issues in Colorado. And we're going to articulate a model process for this using lessons learned from the Perinatal Substance Use Data Linkage project as a case study example. In doing so, we're trying to highlight three big things. One is the value and process of linking data. The second is the importance of building partnerships. And the third is really the role of legislation in creating those sustained solutions that we're driving towards together. So we're going to begin our time together with grounding in what is the data linkage project that serves as our case study. Throughout, we're going to be departing those lessons and highlighting those different areas that we hope to be as takeaways for you all. And then we'll really reserve quite a bit of time for discussion and opportunities for you to translate this into your own work. So let's start out with, where did this project even begin? When we think about its origins, we remember that it started with a fundamental recognition that comprehensively addressing perinatal substance use requires Colorado-specific information on incident and prevalence rates, on health outcomes, and service utilization patterns. Because together, these are the data points we need to inform our policy and practice decisions. And this, of course, is not unique to the perinatal sphere. This is true for many of the work we do on substance use disorders in the opioid epidemic. And so the Colorado's legislature's Study Committee on Opioid and Other Substance Use Disorders responded to this need with Senate Bill 19228, which you might remember as the Substance Use Disorders Prevention Measures. This bill authorized a data linkage project aimed at using administrative records to inform and advance state policies and programs that strengthen families impacted by this growing issue. And the goals from the very start were really twofold. The first was to connect data from state-administered data systems to gain a more 360 view of this issue. And the second was to generate population-level estimates of perinatal substance use in order to guide investments and really track our progress on a more collective level in the state. Recognizing that lots of work is happening in different areas, how do we see the collective impact of that work as it impacts Colorado communities? And as so many of you are familiar with, and this even came up in the little breakout session I had at the beginning, it can be really difficult to estimate how many Colorado families are impacted by substance use during pregnancy without connecting information across our data systems. And this is true for many of the issues this group grapples with. In our case, this is because dyads of pregnant people and infants can touch one system or multiple systems during their childbearing and recovery journey. So if we only were to look at data from any one of those systems alone, we would never have that complete picture. And this is why Senate Bill 19228 was such a critical first step to feasibility of this project. It provided the initial legislative authorization to link data across systems. And then as we began the project with this first foundational bill, we realized pretty quickly that the role of legislation was not a one and done in a project of this kind. Rather, we found ourselves in an iterative process, whereas we talked to our data partners and began discussing project goals, we quickly realized additional legislation is going to be needed to overcome barriers to data sharing that might be specific to a given data source or a data partner, and to really make sure that we kept the project grounded in what was feeling actionable for Colorado decision makers. And that's where we started to then introduce Senate Bill 20028, and then most recently Senate Bill 21137, known for many as the Behavioral Health Recovery Act. This provided some additional legislative language needed to add in some sources, make those linkages more feasible, and really keep the goals grounded in what our decision makers were saying was prime on their mind. I'll also just take a quick moment to make note on this slide that this is really, when we think about the role of legislation, not just about feasibility of data linkage, but also having our legislative partners throughout the project has been critical to getting information into the hands of those positioned to invest and help make sustained systems level change. So when we think about the partnership piece, really thinking about what's the role of our legislative branch in sustained solutions and data linkage work. So right about now, you might be thinking, well, what data sources were included in all this legislation? And so we have this graphic here on your screen that really helps to articulate the data sources that have been prioritized for linkage through this project. To date, we have successfully linked vital records data, including both live birth and death records, with TRAILS data, which is the data system for child welfare. So we really started this project with a key priority area around what is the risk and protective factors for child welfare involved maternal infant dyads that have their involvement due to substance use during pregnancy. This is a big piece because when we think about that life course perspective and we think about upstream prevention, we need to be thinking about those early dyads and early family formations. So then we started with that. That's really where we began to generate those population level estimates and move forward with some of the so what implications for policy and practice. Clearly alone, that's not enough. So next up, we're starting to prioritize in the project the prescription drug monitoring program data, medical assistance program data, and Colorado Hospital Association data. And these data sources are next up in the priority list because they're the most critical to generating the population estimates needed. When we then combine those with data from other sources, such as the Colorado Child Care Assistance Program and the behavioral health programs that we run in the state, we're able to start to look at things like service utilization patterns and well-being outcomes. And we try to do this all the way from pregnancy through the first year of life. And that really brings us to what makes a data linkage project like this so unique and one of its first of its kind in Colorado. We really think about three essential elements to what a data linkage project can help us do that we might not be able to do without that key fundamental part of it. So the first is that throughout the project, we link data not only across systems, but we link data for the pregnant person and infant as a unit, recognizing that their health and well-being are inextricably linked. In doing so, we're able to analyze the outcomes for the dyad together and think about solutions that support that unit and by extension, the whole family. So we're not just thinking about solutions that will just serve the pregnant person, but maybe not that infant, or just serve the infant, but leave out their parent or leave out their family. We're looking at the data in a way that lets us develop the solutions in tandem. Second, while many projects are only able to look at data from a certain period of time, this project from the start really intentionally looked at outcomes and service navigation patterns from pregnancy all the way through the infant's first year of life. This really allows us a more real life look at how things change across time and space and allows us to get a little bit more specific and concrete about where intervention and support may be needed. So we're not just stabbing in the dark about where we might want to invest in supports, but rather have an opportunity to see that through kind of a more trend analysis and how things change over time. Third is that families don't operate in any one system. That is probably clear. And so by breaking down those data silos and linking data across our systems, we're better able to mirror the real life experiences of families who in their journey will cross our systems. They'll cross public health, they'll cross criminal justice, they'll cross housing, they will cross treatment, they'll cross behavioral health programs. And as they cross those systems, we need to make sure that our data don't stay siloed because their needs are not siloed. And that, as you can imagine, a project of this kind really is not possible without true collaboration. So I kind of noted the importance of partnership with the Colorado General Assembly, but who else? You see kind of a sampling of some of our key partners in this project on your screen. And what I'll emphasize here is that from the start and ongoing, this project really was designed in partnership with state agencies, with nonprofits, with families, and the research community. One of our essential elements at the Colorado Lab is building trusting relationships and making connections for sustained change. So in this project, what we started to do was listen to what each partner needed, how they could use the data, and then that led us to be able to find the right project priorities at the right time and the right approaches to analysis that would keep the project rigorous, relevant, and actionable. So with those foundations in mind, I'm going to pass it to my colleague Alicia to get us into more of the detailed how behind the data linkage work we've done to date.
Thank you, Courtney. As we talk about the methods, we'll keep it relatively high level, but we've been told that this is the group of data geeks. So please do jump in with any questions, comments, suggestions, wonderful opportunities as we look ahead. We welcome all of those because in many ways, you are truly our favorite audience to talk with about research studies. So we can go on to the next slide. So for this very first part of the perinatal substance use data linkage project, as Courtney mentioned, it's based on the cohorts of maternal infant dyads that we were able to develop by linking vital records to child welfare records. So these are the maternal infant dyads who were referred to child welfare shortly after the birth of an infant for substance exposure of a newborn. We also limited it to Colorado residents at the time of birth so that we could leverage those birth certificate records. And these are the dyads that met the definition of substance exposure during the prenatal period, and it was substantiated by a child welfare agency, meaning that there was very clear evidence that there were effects of substance exposure on that newborn and evidence that there was substance use during that prenatal period. The reason that we focused on this cohort first were twofold. The really practical of feasibility of linking those two data sources. We have wonderful partners at Department of Human Services, lots of familiarity with the child welfare data, and wonderful partners at Department of Public Health and Environment for those vital records. But also there was really actionable steps that we knew we could take pretty immediately if we focused in on this child welfare involved population. And we also know from the literature that separating an infant from their mother can disrupt that early bonding and healthy development. And it can create stress for that postpartum person and the entire family. And so there were very clear opportunities to think about if we put the spotlight on this issue and we identified some of those risk and protective factors, ways to focus on cross-system coordination to prevent family separation, and also to decrease the need for foster care placement and strengthen families in the long term. Next slide, please. So when we zoom out and say, okay, how did we do this? Legislation was the first step in many ways of being able to authorize a very complex data linkage project for a highly vulnerable population. And just because it's authorized and in legislation as something that we need to do, that doesn't get us to actually doing it in the how. The how we did it and how we're linking all of these data sources that were pictured in that circular diagram that Courtney walked us through is through the Linked Information Network of Colorado, or LINC. LINC is a partnership between the Colorado Lab and the Governor's Office of Information and Technology. And what it does is it sets up the governance process, the data sharing agreements that are standing, and the partnership agreements so that state agencies and other data contributors as well can review projects under master agreements and then make a decision very quickly, typically in a matter of weeks, rather than you all who have set up data sharing agreements for a specific project know that it's not a matter of weeks, it's a matter of years or a matter of lifetimes in some cases to get those in place. Because we have those standing agreements with many of the state agencies, the decision makers can just approve a project or a use case. And those data that are required only specifically for that project, the minimally required data set, are sent to a data scientist who works in a secure environment in the Governor's Office of Information and Technology to do the linking across the data sources and then anonymizing it for the research team, like, for example, us at the Colorado Lab, or you at an agency, or you at a research institution or a university. This is a system that's available to really activate those data partnerships, link those data, and then de-identify them for research and business analytic purposes and ensure ethical data use. So when we think about this project as a model process for others, that Linked Information Network of Colorado is a wonderful resource if you need state administered data sources connected, but then it's okay to have that as data de-identified. It can still be client level data, but it removes those identifiers of the names, the dates of birth, Medicaid IDs, those sorts of things. Courtney, would you mind dropping into chat the website for links so folks have that if they need it in the future, and then we can move on to the next slide. So where did we land? We landed with a study sample of a little over 4,000 unique dyads. This number may seem a little bit low when you think about child welfare involved, substance exposed newborns, those dyads. Part of that is because when we limited the sample, we did it for those that had substantiated referrals for substance exposure of a newborn. Many counties in Colorado don't substantiate referrals. They have a different model for screening in and providing support, and it doesn't have that definitive yes that there was an issue of substance exposure of a newborn. And so that's why it's a relatively small sample. So this is our known population of substance exposed newborns that are involved in child welfare. There's also an unknown population as well. But within the study sample that we use to explore risk and protective factors, mostly lower income, about half were never married, about 80% white mothers, lower educational attainment on the whole, relative to our Colorado population, with about 63% with high school education or less. Medicaid was the primary source of payment for these deliveries, which is important as we think about bringing in other data sources and really the value of Medicaid claims data and Medicaid becoming a partner in the future, since we know that that's a primary payer for these maternal infant dyads. The average age of mothers was 28 years. And WIC participation was at 46%. And we'll talk more about WIC participation when we get to the findings. So what did we do? We started by just comparing the participation in prenatal care and the adequacy of prenatal care, WIC participation and pregnancy health and newborn health at the time of birth to the general populations. And we did that descriptively. We also looked at some trends in initial child welfare involvement for those maternal infant dyads. We have that information available in some research briefs. What we're going to focus on today in terms of sharing findings in our limited time together is those risk and protective factors that are associated with infant removal from the home by child welfare and placement into foster care. The correlational analysis we did through binary logistic regression, because that has very direct policy and practice implications that we'll share. And Courtney, I'll turn it over to you to talk about some of those study findings.
Hey. Thank you, Alicia. So in terms of the findings for that specific aim 3, the first thing that we wanted to highlight today around what we learned is we wanted to ask the critical question, what factors are associated with an increased odds of infant removal by child welfare? Because to Alicia's point, this was one of the first places that we can be super actionable. And so we found through the analysis 6 key significant risk factors. The first was increasing maternal age of the mother or the pregnant person. This is always a question every time we give this presentation. So I'm just going to share some of the insights as to why. We don't know why, right? Because we're only looking at administrative data. But we know from some of the other research and discussions with partners that are moving these data into action that oftentimes we find that older mothers may not always have the same level of social support in their life because maybe they don't have a lot of friends who also has a baby at 6 months, right? Old. And so we want to be thinking about what it looks like to remember that pregnancy is not created equal for everyone. And what does this mean in this case for an increased risk of removal from the home? We also saw a lot of social and economic and health vulnerabilities, such as lower income households having increased odds of removal from the home of their infant. Third was lower educational attainment by the pregnant person. Alicia noted that in the sample description. And in fact, we saw this show up as a factor that was associated with increased odds of infant removal. And about 63% of the sample had that high school education or less. And we really saw that as a pronounced place that we want to think about modifiable factors. The next is around maternal and infant dyads who receive no prenatal care or inadequate prenatal care. This is really interesting because this sample experienced inadequate prenatal care, meaning less than the recommended amount by normal standard hospital care, at twice the rate of the general birthing population. And prenatal care is also a modifiable risk factor. And finally, infants that were medically fragile due to things like preterm birth and respiratory distress were more likely to be removed from the home. And we call that medical fragility of the newborn. They might require additional care that isn't always clear how to care for that infant. And so what can we do to think about that as a support for families when a medically fragile infant is born? Now, really importantly, for the infants that are removed due to those risk factors and more, trends since 2015 indicated a decline in the rate of what we call kinship care. So kinship care simply means that when a child is removed from the home by child welfare, it's placed with other family or relatives versus, for instance, non-kinship foster care, which would be somebody else, right, who's serving as that foster home. Now, kinship care is considered important because it is a best practice for promoting healthy child development and strengthening the family network so that reunification between the parents and the infant is more likely to occur and the family unit can hopefully be stabilized long term so we don't see that same recurrence in systems involvement. And at the same time, as we're seeing like this opioid epidemic, all of this work within our LINC data set and the removal of the home trends, we're seeing an 11% decrease in placement of newborns into kinship care for this population. And it dropped from about 38% in 2015 to 27% in 2019. So that is not a trend that we're particularly excited about, and it has some direct practice implications. And so it's something that we're watching closely, and I think is a great use case example of why LINC data. We wouldn't necessarily have any idea that this trend was happening for this population in particular without this particular LINC data project. Now, in addition, we don't want to just look at deficits. So next we work to answer the question, what factors are associated with a decreased odds of infant removal? Here, we found 4 significant protective factors. The first is individuals who identified as Indigenous were less likely to experience infant removal. And this may be connected to what we call ICWA or the Indian Child Welfare Act. So that's a policy piece that provides additional protections to Indigenous communities that may be at play in this particular finding. Second, we found that marital status mattered, and this may be due to additional social support built into that partnership. Not a given, but a potential why behind the what of that data trend. Third, and again, really interesting, Alicia teed this up, is we would return to the WIC finding. And that is because maternal infant dyads who received WIC during pregnancy had a decreased odds of removal. And really importantly, while 46% of all mothers participated in WIC during the pregnancy in our sample, household income data suggested that far more were eligible to receive the benefit than did. So there's a gap between what's a protective factor, who's receiving that protective factor, in this case, a public benefit like WIC, and what we might be able to learn and activate on a policy or practice level to shore it up and close that gap. And finally, deliveries paid for by private insurance had a decreased odds of infant removal. And yet we saw Medicaid was the primary source of payment for 83% of deliveries. So again, what does it mean to add in these additional data sets that really help us to investigate something like that deeper and further? Finally, we believe that building evidence on what works and having a data-informed understanding of inequities are key elements to moving toward fair and just policies, systems, and practices for this population. So we also work to examine if there is any evidence of disproportionality of infant removal by race and ethnicity. Now, we couldn't do a ton for this first foray into this work because our sample sizes were simply too small, but we were able to examine this for Black and African American individuals, and we saw no difference in terms of the different factors we looked at and the rates. So it's something that we're going to keep our eye on. Like I said, sample size is small, but we were able to look at that up front. It's something we continue to prioritize in the project. So with that, I'll turn it back over to you, Alicia, to take us home with practice implications and where we go.
Sure, thanks. We can jump to the next slide. All right, so when we think about implications for policy and practice, we're really focused on what are those modifiable risk and protective factors that we can use as levers to help keep infants safely at home with their families, because that's the goal, is that family preservation and doing it in a safe way. Increased consistent participation in prenatal care is a strategy that, based on this initial research, could help, because we saw those very high rates of inadequate prenatal care. So that early access to medical providers and the adjacent supports that they can provide to set up a family so that they're ready to take care of an infant affected by substance use during a pregnancy. And all of these strategies are really about investing in concrete supports that wrap around families. It's the public assistance programs, it's the prenatal care, it's the community supports. They're all just that interconnected piece of how do we set maternal infant dyads up on a trajectory for success during that pregnancy, successfully exiting that hospital experience, ready to come home and take care of that infant in a safe environment, and through that first year of life and long term. And improving WIC participation, as Courtney mentioned, there was a clear gap between the number of mothers eligible for WIC and those that were accessing it. And thinking about WIC as, again, an entry point for multiple services and connecting to the supports that are needed to be successful, so that we're targeting supports for those families. You see in gold highlighted under the well-being piece, the use of plans of safe care as a strategic lever. Plans of safe care, they're a document, but it's really a process for identifying and putting in place what does a family need to be successful in safely caring for an infant affected by substance use. Currently, plans of safe care live in child welfare, and they are used as a mechanism to help set those families up on a trajectory. But we're piloting, which is really exciting, through a partnership with the Department of Human Services, pulling that use of plans of safe care out of child welfare and into the community, thinking about how prenatal care providers, how folks that are connecting with families in the community, maybe through WIC services or other services, can start setting families up safely to take care of those infants and be on a trajectory for success. The home visiting programs and other investments as well. along those same lines, because there's wonderful work in Colorado associated with the NICUs in particular, and the Chosen Collaborative for those really medically fragile infants that are affected by substance use. And we want to use the Plans of Safe Care pilot to set up that same level of support for those infants that maybe are less medically fragile, that we can identify early before the birthing event and set them on a path for success. Courtney, is there anything you want to say about that as well?
Only thing I would say is that as we launch this particular partnership, we are also working with the Kemp Center and Illuminate Colorado to really make this a process that can accelerate the good work being done in the state and bring it into a framework that can be replicated and sustained long term. So this pilot is just starting. We're quite literally in the planning year, and any of you that have interest in this particular issue and that really want to help be partners in this work, we welcome a discussion. We're actively looking for communities that have readiness factors to launch a pilot of this sort, and we'd love to get in touch to talk about how it might complement existing efforts.
Thanks. I think we can move on to the next slide. So some of the lessons we've learned so far from this data linkage adventure is starting with the very obvious, that it really is necessary to link data from across multiple systems to generate comprehensive estimates of really many social issues. This isn't specific to substance exposed newborns. This applies to individuals experiencing homelessness. It applies to substance use more broadly, not just in the pregnant and parenting population. But really, our families in Colorado touch many different public systems. And when we can invest the time and the resources in connecting that information, we have a much more comprehensive picture, not just of the estimates, but also the system utilization, where they touch the systems, how to better support them, and the outcomes that we care about in terms of safety for our Coloradans. And we have the capacity in Colorado to do that, especially with leveraging the linked information network of Colorado. We've also really focused on the value of legislation. The Consortium for Prescription Drug Abuse Prevention has been incredible partners as throughout the process of working with our legislators to design and authorize data linkages that would not have been possible otherwise, particularly for this population. And using that in concert with national guidance from SAMHSA around using substance use data that is part of the Medicaid claims data and the hospital claims data has been very helpful. Those partnerships, you know, Courtney touched on that with the slide illustrating the state agencies, the nonprofits, the research partners, the community partners, the family voice partners that have been so central to generating actionable data. Because we all have a different lens to bring to this and all have different positioning to be able to invest and to act and to leverage information. The Plans of Safe Care pilot is one very concrete example of Department of Human Services being uniquely positioned to act and invest when they saw some of these initial results and say, we can redirect some CAPTA dollars in order to test drive this pilot program outside of the hospital setting. Also, the sustained ongoing research agendas that many of the issues that we work on together are not just a one and done project. We don't want to stop with the child welfare involved maternal infant dyads. We want to be able to continue and expand into leveraging the prescription drug monitoring program data, the Medicaid data, and the Colorado hospitalization data to get good estimates because there are so many unknowns still out there. And then just that evidence-based decision-making process and thinking about the iterative process of leveraging administrative data, then testing solutions, designing programs and policies that are data informed so that we can then scale what works for Coloradans. So we've got just a few minutes left. and would like to open it up for discussion, we put some prompts up here. We can use those, or we can go different directions based on your interest. So feel free to jump in and just unmute yourself.
I have a huge amount of praise for you all. I think that everything that you do is amazing, and thanks for a great presentation. I know that this is a Colorado focused group and a Colorado focused lab, hence the name. However, I'm curious, especially with the infant maternal dyads, how generalizable for a different jurisdiction, a different state that has some type of linked data set as well. And there, as you all know, there aren't a ton, but there are a few around the country. How generalizable is the code? And is there a process for the Colorado lab to make that open sourced code? This is the nerdy question. You wanted nerds, so here's the nerd. Is it possible to make that code open source such that another jurisdiction might be able to replicate or work with the amazing work that you guys have done?
Yeah, so our code really isn't rocket science, Josh, but we are happy to share any and all of it. I do think it's replicable in many ways because it's really a conceptual map of looking at, the information that would be in many of the child welfare SACWIS systems throughout the nation, information that would be in vital records nationwide and the other data sources. I think one of our next adventures is, the PDMP logic, I think will be, and you and I have talked about that a little bit, and you've got some incredible work and guidance on that too. But yes, we're happy to make anything, that's our philosophy, open, public. We can, and in terms of the process for linking data, we have very detailed match reports in terms of how that process was done and the identity resolution that was done across those systems that we are happy to share.
Awesome.
And also,
I would love to hook you all up with people in a few different states that need this work done, and just to grow your lab beyond Colorado.
I don't know that we want to grow our lab beyond Colorado necessarily.
Sorry, when I say grow the impact,
the national picture,
grow the impact.
We have to change our name.
I know.
Stuff.
I meant grow the impact of the lab beyond Colorado.
We would love that. Thank you, Josh.
Awesome. Any other questions or thoughts or comments?
One of the other, while we have Josh talking a little bit, one of the other interesting pieces about generating estimates of an issue is that, we're able to count what we can count. And so we can generate that known population based on multiple administrative data sets. And wanted to flag too, that Josh has a very innovative methodology for generating estimates of the unknown data sets when there are at least 3 different administrative data sets that are linked. If you'd be willing to do a kind of quick commercial on that, I think that would be really helpful too.
Sure. You got me when I stopped chewing. Yeah, no, I think one of the things that's you all highlighted really nicely was that that a singular data set only captures what it captures, and especially with administrative data sets, when we're talking about stigmatized conditions, be they opioid use or homelessness, or you name it, criminal justice records, etc. We know that doctors like me suck at putting things into claims. We don't do a very good job at identifying people. And so there's a growing body of what's called indirect estimation methods. Instead of just counting based on one data set and what you see, you can actually use what you don't see, or what you see to inform what you don't see. So yes, one of those is capture recapture, which comes from Fish and Wildlife. And I think that people on this call have heard me pontificate on before. There are multiplier methods that use fancy Bayesian methods that we've worked on that don't require so much overlap. And so there's, for anyone on this call, I think that the LINC data set and the Colorado lab having all of this together is a unique opportunity to answer some of the unknown questions. And I'm happy to, join calls or answer questions if it's helpful. I mostly just make stuff up as I go along.
Thank you. I think we are about out of time.
Yeah, we have a little bit more time for discussion if there are any questions. Oh, Jose, it looks like you've got a hand up.
What I find exciting about this work is with these partnerships and how robust this is with all the different data sources, we have an opportunity here then to inform multiple disciplines around the impact that this work is having more comprehensively than just the silo piece. But that allows us to think about solutions so differently than if I was just thinking about it from my own perspective, from one perspective only. And I find that very exciting. And I think that really makes it interesting for us in terms of considering practice transformation, practice changes that can improve things, better linkages of services to serve folks better, but also the data to prove the efficacy of those changes. So it's not just a matter of we have an idea that can make it happen. This data can help us determine efficacy as well. And then, of course, when it comes to funding, this kind of data really is remarkable in terms of putting this in front of potential funders who might want to look at implementing some of these new innovative approaches to sustain this kind of work. And of course, I look forward to being able to present some parts of this to our legislative folks over the summertime with the opioids and other SUD study committee as well. So well done. I think it's just remarkable work and very exciting what we can do with this data.
Thank you, Jose.
I think it also, Jose, to your point, I think it also helps provide an actual longitudinal picture of an individual. We, with so many, with one data set, you literally get a snapshot and you don't actually see what might influence, like the social determinants of health that could otherwise be influencing. And I know because I've spent enough time staring at the Colorado Lab's website, what I think is really amazing and remarkable and innovative is that you all have tried to pull in things like from education and from different disciplines, which I think especially, wow, my mind just went in like 17 different directions, but especially as the CDC, for instance, is reorganizing and thinking how they do surveillance data. I think that part of what needs to happen for public health is the unsiloing of data, right? And the sharing across from the Department of, we're going national because we're renaming your lab, just so you know, to the national lab right here on this call. But it doesn't come with increased funding. It's just a different name. It's like most of academics. But I think that cross department sharing is really unique and really necessary so that we can say, look, this person 5 years ago, had X experiences in the educational system. And it's not just that we go to the traditional predictors that they're the age, the race, the income level. It's actually what has happened across a person and their experiences. And I think that especially for mother infant dyads, for homelessness, for substance use in general, that is it's unique and probably much more important for those types of situations than almost any other disease that I can think of.
Thank you.
All right, ladies, there aren't any other questions. Do you guys want to wrap up with your potential action steps for this group?
Sure. So Tiasha, teed us up to tee you up around what could be potential ways to move this forward. And so we just really brainstormed too. One, I think, focused more on, the actual data that have been shared today and how we might advance some of those solutions. And then the other one focusing on our key objective of using this as a model process for where else you might be able to apply everything we've talked about today in your sphere, ideally in Colorado, not nationally. We're still the Colorado lab, just kidding. And so with the other action step, it's really, what practice or policy opportunity can you think about, right? What's rolling through your mind right now as we've been talking of like, ooh, if I had this for X project, I could get this much farther in demonstrating efficacy or innovating solutions or making that, direct modifiable intervention or support or practice that's needed to make a difference. And so be thinking about those, what type of opportunities could benefit from a linked data approach. And then I will drop in for us in the chat our emails so that when you have that idea, you can reach out directly to us and we will get you in contact with the right people to move the idea forward. So I believe that is what we have today. As we end, we'll also just drop in the project page that has a number of reports. And for those of you who want to really dig deep into some of the analytical approaches we've used, has everything from those detailed data matching reports to the legislative actions we've taken to an awful lot of data visualizations about more in-depth data than today. So feel free to check it out at your leisure. And thank you so much for having us. We look forward to the continued partnership.
Awesome. Thank you guys so much, Alicia and Courtney, for all the work that you guys are doing and for this wonderful presentation. I will share my screen real fast. As we wrap up here. Okay, perfect. Great. So as we wrap up here, I just wanted to open up the floor to any folks who might have any announcements about any upcoming trainings, conferences, or general news to just share with the larger group. I'll pause for a second here if anyone has anything to share. Okay. Perfect. So as usual, please share any data reports, findings, news, things of that sort with Junior through the SEOW coordinator email for the SEOW newsletter. And please remember to participate in our post-member or post-meeting survey and also note any topics or briefs that you might be able to be the subject matter expert for. And finally, look out for our next meeting, which will be March 16th from 9 to 10:30. We'll send out some future communication with more information about what the topic will be. And thank you all so much, and we'll see you then.